Hi, it's Nick Theodosakis again, and now we're on to the pharmacology section of the chapter. Admittedly, this section's not too bad relative to some of the other chapters. The drugs here are pretty boards relevant, and you should spend some time getting to know them. Before you can understand how the drugs work, though, we'll need to look at the arachidonic acid pathway and understand the normal physiology before we look at how our pharmacological interventions muck it all up. Though it might take a little extra effort, memorizing this pathway should prove fairly high yield, as it tends to be one of the more often tested pharmacological pathways, since aspirin, NSAIDs, and acetaminophen all affect it in some way and are all really common drugs. If you look at this diagram, the whole process begins at the plasma membrane. A single membrane lipid is taken by phospholipase A2 and is converted into arachidonic acid. With this arachidonic acid, there are two directions to go, either down the lipoxygenase pathway or the cyclooxygenase pathway. The lipoxygenase pathway is simple. Arachidonic acid is ultimately converted into leukotrienes. These include LTB, LTC, LTD, and LTE. LTB4, as you might remember, is responsible for neutrophil chemotaxis. Remember, it's the L from the mnemonic CILK, silk. The other three, LTC, D, and E, are all potent bronchoconstrictors. While you won't see these again until the respiratory lectures, the drugs Xoluton, Zafirlukast, and Montelukast all block this lipoxygenase pathway, as it tends to be an effective treatment option to prevent bronchoconstriction in patients with asthma, especially if the asthma happens to be aspirin-induced. Of course, the mechanisms of these drugs are really easy to remember because they all contain Lu in their names, just like leukotrienes. The second pathway that arachidonic acid can take is the cyclooxygenase pathway, or the COX-1 and 2 pathway. This converts arachidonic acid into three molecules. The first two are in some sense mirrors of each other. Prostacyclin, or PGI2, decreases platelet aggregation and also vasodilates. Thromboxane, on the other hand, increases platelet aggregation and vasoconstriction. You can kind of keep the effects on platelets straight by just remembering that aspirin works on thromboxane and that aspirin decreases platelet aggregation. The balance of these two molecules actually ensures that vascular tone is being regulated appropriately, as is the appropriate activity of hemostatic pathways. The third product are the prostaglandins, like PGE2. They've got a wide variety of effects, including decreased vascular tone, increased pain sensation, increased uterine tone, and increased temperature. For example, PGE2 is actually the molecule responsible for setting off the neural signals for a fever. A lot of drugs affect the COX pathways, especially the NSAIDs, as well as acetaminophen and acetylsalic acid, or aspirin. All of these are nonspecific and block both COX-1 and COX-2. There are also specific COX-2 inhibitors that allow the COX-1 pathways to remain intact. We'll talk about those in just a few minutes. Lastly, you'll want to know about corticosteroids. They also function to block arachidonic acid production by decreasing activity of PLA2, as well as protein synthesis that creates the enzymes COX-1 and COX-2. They function by decreasing activity of phospholipase A2, as well as protein synthesis that creates the enzymes COX-1 and COX-2. By doing so, steroids can also be potent anti-inflammatory drugs. Like we already discussed, aspirin functions by blocking the COX enzyme. You'll definitely want to remember that aspirin does this by irreversibly inhibiting via covalent acetylation. This reduces production of inflammatory mediators like thromboxane A2 and prostaglandins. It also means that aspirin's anticoagulating effects last anywhere from 7 to 10 days. Or in other words, the time it takes for the body to replace those platelets. The interesting facts about aspirin actually come from the fact that at different doses it does different things. At the lowest doses, it's responsible for decreased platelet aggregation, which is important prophylactically for people at high risk for heart attacks. The second dose level is intermediate dose, from 300 to 2400 mg per day. This helps prevent fever and pain. It's actually the highest doses that are required to decrease inflammation in the way that we need if there is concern about inflammatory response. The concerns with aspirin aren't trivial, despite the fact that it's such a commonly used drug. The most common is probably gastric upset, which can predispose to gastric ulcer formation, which can lead to upper GI bleeding. Also, aspirin's got a complex relationship with the kidney during excretion, and aspirin can predispose to acute renal failure, as well as interstitial nephritis. Children used to take aspirin commonly as an antipyretic when they had viral illnesses, but it was noted that these children developed Reye's syndrome, which is marked by neurologic disease, when they did. As a result, doctors started recommending that obviously they not take it. Today, the only real use for aspirin in kids is when it's used at high doses to treat Kawasaki disease. In this case, the benefits greatly outweigh the risk to treating. Aspirin can also cause tinnitus, or ringing in the ears, in some patients. The next category is a big one, NSAIDs. There are a lot of them, but you should at least be familiar with ibuprofen, naproxen, indomethacin, and ketorolac. The big difference between most NSAIDs and aspirin is that NSAIDs cause a reversible inhibition of COX enzymes. The uses, therefore, are really similar, with antipyretic, analgesic, and anti-inflammatory uses, but not as much of an antiplatelet effect. Indomethacin is also classically used to close a patent ductus arteriosus. The downsides of taking NSAIDs, just like aspirin, are pretty important. Again, the really common one is gastric upset, which can manifest eventually as gastric ulcers. You can also get renal damage over time due to the disturbance of renal vasculature. This is due to changes in native prostaglandin levels. Patients may also experience aplastic anemia as a rare idiosyncratic response to taking NSAIDs. The COX-2 inhibitors are another class of drugs, but in America, the only one that's still available on the market is celecoxib. The goal here is to specifically reversibly inhibit COX-2, but keep COX-1 levels normal. The idea here is that COX-1 is thought to be found in the GI tract, and the GI upset, a common reason to discontinue NSAIDs, might be avoided if you leave COX-1 alone. COX-2 is also the isoform that's thought to be more responsible for inflammation and pain anyway. So regardless, it's really the one that's more important to block. Clinically, patients with a history of gastritis or ulcers that otherwise can't take NSAIDs may benefit from COX-2 inhibitors if they have a chronic condition like osteoarthritis or rheumatoid arthritis. These are generally the only diseases for which you'll see COX-2 inhibitors prescribed. The big concern with COX-2 inhibitors is the highly publicized risk of thrombosis. Also, these are sulfa drugs, so keep in mind you can't give them to someone with a sulfa allergy. Another commonly used drug for analgesia and antiparesis is acetaminophen. Here, however, the drug functions by reversibly inhibiting COX in the central nervous system, and not peripherally where it's made inactive. Since it can't get to the sites of inflammation directly to block COX, it's got no anti-inflammatory effects, and it's not technically an NSAID. The benefit here, though, is that children with fevers can take this drug to reduce the fever and avoid the risk of Reye's syndrome. You'll want to keep in mind that acetaminophen is metabolized in the liver, and that this is dependent on the level of glutathione, which normally neutralizes the toxic metabolites of acetaminophen. If you ingest too much, toxic hepatic necrosis can result, which can be life-threatening. The antidote is N-acetylcysteine, which is responsible for restoring normal levels of glutathione and reducing levels of what toxic acetaminophen metabolite? If you guessed NAPQI, you're correct. Next, let's look at an important drug group in the treatment of patients with osteoporosis. Bisphosphonates are a relatively new class of drug and have a lot of members, including pomedronate, alendronate, and others ending in dronate. The idea here is that these drugs inhibit the ability of osteoclasts to break down bone. Clinically, they've been very effective for postmenopausal osteoporosis and have reduced the risk of fractures in multiple sites of the body. You can also use these drugs in other diseases, namely malignancy-associated hypercalcemia and also Paget's disease of the bone. The side effects listed here are pretty classic, and since these drugs are taken really frequently, they're worth remembering. Just as with a lot of other drug classes, there are non-specific side effects like nausea and diarrhea. More importantly, what you'll want to remember is that you can see corrosive esophagitis and osteonecrosis of the jaw. Corrosive esophagitis occurs because of a change in acid production and reflux. As a result, it's really important to take these pills around meals and also to remain upright for some time after ingestion. Both of these are pretty unique toxicities, and as we've said before, unique toxicities love to get tested on step 1. Here's a picture of osteonecrosis of the jaw, just in case you're having trouble imagining it. While we did discuss some of the treatment options for gout, including NSAIDs for acute flares, and colchicine, allopurinine, and probenecid for chronic control, we didn't discuss why they're effective medications and how they work in the first place to improve symptoms. Let's start with colchicine. The idea is that colchicine binds to and stabilizes tubulin in microtubules, which decreases polymerization. This helps prevent leukocyte chemotaxis, meaning that leukocytes have difficulty getting to the site of inflammation and inadvertently causing more damage. As a side note, remember certain chemotherapy drugs also work by altering microtubule function, such as vincristine and vinblastine. The problem with these drugs, despite their efficacy, is that they have awful GI side effects, especially when you take them orally. The reason NSAIDs are more often used is because they have more tolerable side effects. Before we talk about probenecid and allopurinol, we should look at the normal pathway for uric acid production. Biochemically, purines come both from our diet and also from native nucleic acid metabolism. These purines are broken down by an enzyme called xanthine oxidase, which turns them into uric acid. This uric acid goes to the kidney and is dumped into the glomerulus and reabsorbed from the urine at the proximal tubule. In chronic gout, treating with allopurinol is effective because you inhibit the action of xanthine oxidase, preventing formation of uric acid in the first place. This causes decreased serum uric acid levels. As we discussed earlier, you can also use this drug in leukemia and lymphoma to prevent tumor lysis-associated urate nephropathy. Also, if patients are actively taking azathioprine or 6-mercaptopurine for a different indication, patients might not want to take allopurinol because these drugs are metabolized by xanthine oxidase, and using allopurinol might cause the drug to build up to toxic levels. I like to keep the mechanism of allopurinol straight in my head by remembering that it starts with the letter A for antagonist, which helps me remember that it inhibits the xanthine oxidase enzyme. Probenecid, the other option for the treatment of chronic gout, works by blocking the reabsorption of uric acid at the proximal tubule. This allows more uric acid to continue through the nephron and ultimately be excreted in the urine. Interestingly, probenecid also has the side effect of inhibiting the secretion of penicillin, something you'll want to be aware of if the patient's on penicillin and on probenecid at the same time. The way I like to remember probenecid's mechanism is to remember it starts with the letter P, and it reduces uric acid levels by making you pee uric acid out. NSAIDs and glucocorticoids are commonly used to treat acute flare-ups. This is due to their effectiveness in quickly reducing the painful inflammation associated with gout. There's been some thought that salicylates like aspirin might improve uric acid excretion, but in fact this only occurs at really high doses and is still only a really small effect. At more common doses, salicylates actually serve to increase uric acid retention. The last class we're going to discuss in this chapter is the TNF-alpha inhibitors. There's 3 of them you need to know: etanercept, infliximab, and adalimumab. They all do the same thing, which is block the function of TNF-alpha, but they do it differently. Etanercepts are a recombinant form of TNF that binds to TNF receptors, blocking normal TNF from entering the sites. You can remember this by remembering that etanercept is a decoy receptor for TNF. Infliximab and adalimumab, on the other hand, are actually antibodies that serve to mark the TNF molecule for immune destruction. Etanercept and adalimumab have the same indications, including rheumatoid arthritis, psoriasis, and ankylosing spondylitis. Infliximab only differs in that it's not approved for use for psoriasis, but it can be used to treat Crohn's disease. As you might remember from the earlier chapters, the toxicity of the TNF-alpha inhibitors is they may predispose to infection because they're modulating an important part of the immune system, and the most important of these infections is reactivation of latent TB. This is why all patients who will be started on TNF-alpha inhibitors must have a negative PPD prior to getting treated.